This is Peter Minio from the Delaware Regional Extension Center, and I'm here today with Dr. Stolar and her office manager, Kim Arcuri. How long have you been live on your current EHR?
Since January 2009.
Well, I think as far as what the patients are involved is that the clinical summaries that we print out for the patients at the end of their visit gets them more involved in their patient care because they leave here knowing why they were in the office, what medications that we show listed, their vitals, their height, their weight, so they can review it and make any corrections if we have anything, if there's any discrepancies, they're aware of it.
That's great.
If there are any new allergies or any other issues, whether there are other medications prescribed by other physicians that we're not aware of, they can actually come back to us and tell us, gee, I have this allergy, gee, I've got this new medicine, which we didn't have before. We've always paid attention to blood pressure, weight, and cigarette smoking, but I guess in a way it makes us more aware that we need to make a greater effort to get educational material to patients about cigarette smoking and adverse effects and how to help them stop smoking.
Okay.
I think the initial barrier was transforming paper to electronic. Dr. Stolar's been in practice for over 20 years, and the amount of charts that she's accumulated over the years to be able to scan those individual charts into the system to go fully electronic, that was a huge challenge in itself. And then as far as electronic goes, I think to be able to implement the computer in the exam room to kind of get a system as to what works best for us, we're still kind of working through that. Security issues, I think STI has been wonderful as far as helping us through our security issues, to make sure that we do have passwords set, we do have password lockout after a certain amount of attempts, even in the exam room, locking it out so patients can't get in, to the actual EHR.
And as far as safety, I do have a laptop that I take home with me, sometimes to finish work, and I can also look up patient data if I need to from anywhere, and that is security protected by my fingerprint, so no one can actually, even if they get hold of my computer, cannot do anything. And the other issue we've implemented in this office, we've put in a camera. There have been some issues here of some copper thefts in this area, so we implemented a camera system in the back room. And actually, one of our technicians forgot to shut down the camera, and the police came in here because she went into the back room, and the camera picked her up, and there was a silent alarm to the police. So I think we're well aware that nobody can actually abscond with patient data. I think we can both agree that we like the way the chart maker is set up with all the patient demographics on the left side in the chart maker.
In the face sheet.
In the face sheet. You've got the diagnoses, you've got patients' allergies, you've got patients' previous surgeries, you've got their medications that you prescribe, medications that other physicians have prescribed. And that's really great at a glance, because if you're going to try to write for something, you know what the patient's on. The only downside, it does take a long time on older patients to get that left side of the face sheet populated, because you've got a big chart. You've got to go back and see when the patient had his first pacemaker implanted, his second pacemaker implanted, etc. New patients are really easy because you just populate as you come in.
And it's great because it does have everything. It summarizes everything right there. So you can customize the face sheet. So not everybody's face sheet is the same. In the beginning, we didn't have vitals on the left-hand side. Now we do, because of the fact we want to be able to see the last vitals, the last blood pressure, height, and weight before we take the next one, because we are electronic. We're not still thumbing through the chart. Well, in the beginning, I had worked with Wanda, and she was very helpful. A lot of the stuff that I was aware of, because I did a lot of the research myself, but she was there kind of side by side with me to help make sure that we were meeting the benchmarks that we were supposed to be at, and making sure that we signed up and registered under PICOs, and then one of the most important issues was the security officer. Nick Heasters, I believe his name is. Yes. He really helped us get to where we were supposed to be with our security measures. I mean, it is a small practice, so it is the doctor and myself, and we really had the security measures there, but they weren't technically written in a policy and in a format that they should be, and they helped us get on target with that. I think Dr. Stolar and I were just talking about it recently, as far as we're still currently on paper faxing back and forth, and I think somewhere down the line we'd benefit from an electronic fax where we're getting the documents faxed over directly into the computer, and vice versa, being able to send them out electronically. Because when we do have medical documents requested from us, as opposed to the way it was before, is going into the paper chart and just thumbing through it and popping it in the fax machine and faxing it out and refiling it back. Now we have to go in and go through the organizational field on the clinical side and open up each individual thing, make sure it's what we want to print. We have to print it out, fax it, and then ultimately we're shredding it. So it's kind of a waste of paper. I just feel like you need to have everybody on board. Dr. Stolar's practice is a small practice, so it was easy for the two of us to work together, because there were a lot of things that after researching it and finding out that we needed to do, I just told Dr. Stolar this is the way it needs to work, and we worked together, and she implemented it on her part as well as I did on my part. So you really do need teamwork for it to actually work.
It may be harder in a bigger office because you've got more people to do that, but it's just the two of us, and she'd say, well, we need to do this, and I'd say, okay, how can we implement this? And we work together to implement it. It may be a little more difficult in a multi-office where you have some people that are resistant to change.
That happens.
Definitely.
It doesn't have to be a large office.
Then you have to be open to change for it to work. Otherwise, it
you
won't
have to
work.
want to grow.
That's right.
Definitely.
That's right.